आणि आपल्याला आज जे लास्ट स्पीकर लाभलेले आहेत डॉक्टर पंकज तोतला सर, कन्सल्टंट न्यूरोसर्जन, आदित्य बिर्ला मेमोरियल हॉस्पिटल पुणे, एक्सपर्टाइज एंडोस्कोपिक स्कल बेस्ड सर्जरी, वैस्कुलर न्यूरोसर्जरी, मिनिमल इन्वेजिव स्पाइन सर्जरी, publications in World Neurosurgery, JNRP, AGNS and others, member NCI, Skull Based Surgery, Society of India, Royal College of Surgeons, London. Sir, I invite you on stage for your lecture.
Good afternoon, everyone. Thank you so much, NIMA, for inviting me here today for the endoscopic spine surgery lecture. So today's lecture is about endoscopic spine surgery, a practical guide for the general practitioners. This entire presentation is actually divided into 12 chapters. Each chapter is going to take less than 5 minutes, and in each chapter we will discuss things about the endoscopic spine one by one. In chapter 1, I am going to introduce you to the endoscopic spine surgery. Here we will understand the fundamentals of this advanced surgical technique and its relevance into your clinical practice. First of all, why endoscopic spine surgery is required? Because of 3 reasons. Number 1 is it is ultra minimally invasive. We take very tiny incisions, typically just 5 mm incisions for this surgery. This minimizes the disruption to the surrounding muscles and tissue. Number 2 reason is advanced visualization. An endoscope is equipped with a high definition camera and a powerful fiber optic source which provides a clear and magnified view of the surgical area. And number 3 reason is targeted treatment. This allows surgeon to precisely address the conditions like herniated disc, spinal stenosis, with significantly less collateral tissue damage compared to the traditional open surgery. We'll discuss these points one by one. We'll start with the ultra minimally invasive. What do I mean by that? So this is ultra minimally invasive surgery. The entire surgery is performed using just 2 5 mm cuts. And this is the post-operative dressing using just 2 band-aids, that's it. This is another patient, 1 month post-surgery. Even I had difficulty in finding out where the scar is. So this arrow here is a surgical scar, barely visible. So this is the picture of progress. This is the open spine surgery, scar of the open spine surgery. This is a microdiscectomy surgery scar, and this is endoscopic spine surgery. And this is the kind of visualization we expect in endoscopic spine surgery. You see here, this is the cord here. You can see each and every vessel on the cord very clearly. And this is the disc space here. With this kind of visualization, the chances to the injury to the cord or nerve root is close to 0. So this is the evolution of spine surgery. First we started with the traditional spine surgery, where we used to take a long midline incision. The muscles were dissected. The lamina, that is the posterior part of the vertebra, is removed. And then the cord and the nerves are free, and then the disc is removed. This led to significant blood loss, prolonged and painful post-operative period. Then came the era of minimally invasive spine surgery, also called as microlumbar discectomy, which includes introducing the smaller incisions and the tubular retractor. But again, the problem here is still there is muscle damage leading to post-operative pain and trauma. And recently, in last 1 decade, we have introduced the endoscopic spine surgery, which is the apex of minimally invasive technique, using real-time video guidance through an endoscope for unparalleled precision and the minimal tissue disruption. Now, why should a GP should care about the endoscopic spine surgery in your clinical practice? It's because of 3 reasons. One is the patient demand. Patients are increasingly aware and requesting for the less invasive treatment options that promises quicker recovery. Second reason is improved outcome. Early and appropriate referral for endoscopic evaluation Early and appropriate referral for endoscopic evaluation can significantly improve the patient outcome and satisfaction. And last, informed counseling. Understanding the indication and benefit allows GPs to provide better guidance and manage patient expectations effectively. Now in chapter 2, we will understand the common spine conditions that can be treated endoscopically. Number 1 is the herniated disc. You see this MRI here. So this is the sacrum here. This is the L5 vertebra. This is the L4 vertebra here. This is the L3 vertebra. This is the L2 vertebra and so on. This is basically posterior side. This is the anterior side, and we are looking from the side. Alright? And this structure which you see, the blackish thing, between the two bones is the intervertebral disc. This is the cord which ends at L1, and there are nerve roots below that. And this white thing is basically CSF. You see there is a large disc bulge here into a spinal canal. It's called as prolapsed intervertebral disc. This occurs when the nucleus pulposus comes out of the annulus fibrosus, pressing on the spinal nerves, which can lead to sharp radiating pain down the leg, tingling sensation in the legs, and patient can have localized muscle weakness. The primary causes include age-related wear and tear, but can be triggered by improper lifting and acute trauma. The second condition which can be treated endoscopically is spinal canal stenosis. This is a normal spinal canal here, which you can see at the level of L2, L3. While at the level of L4, L5, you can see there is significant compression anteriorly and posteriorly, and it's called as spinal canal stenosis. The patient predominantly present with the claudication pain. Patient do have significant buttock pain or calf pain while walking. They also have back pain that eases with leaning forward and numbness or tingling in the foot and leg. This symptom often develop gradually and most prevalent in patients over 50 years of age. The third condition which can be treated endoscopically is spondylolisthesis. Listhesis is basically slippage of one vertebra of one above the another. You see there is a spondylolisthesis at L4, L5 level in this picture. In this, the discectomy is done endoscopically, and then the screws are placed percutaneously. Other indications where the endoscopic surgery play a key role is foraminal stenosis, recurrent disc herniation, and recurrent spondylolisthesis. In chapter 3, we will basically understand the patient evaluation and the diagnosis. It is a systematic approach to identify the right candidates for the endoscopic surgery. Low back pain is one of the most common presenting complaints in the clinical practice. Accurate differentiation between the mechanical, inflammatory, infectious, and serious pathological causes is essential for appropriate pain management. Before we hop into the differential causes for the low back pain, I would like to tell you a story. Recently, we had a patient in the OPD who was operated in one of the famous hospitals in Pune. Patient had significant left lower limb radicular pain in the preoperative period. MRI was done. MRI showed some L5S1 disc prolapse. Patient got operated for the same. Even after surgery, the patient had persistent pain in the left lower limb. The repeat MRI was done. Repeat MRI showed again the same thing, a small disc bulge at L5S1 level. Patient was planned for the redo surgery. Patient was operated again at the L5S1 level. Even after surgery, second surgery, patient had persistent pain in the lower limb. Now the MRI was done again, and this showed some small disc bulge at L3-4 level. Patient was given option for the surgery again. Patient denied surgery and then came to Aditya Birla. On careful examination, basically we found out the patient has piriformis syndrome. The hydrodissection of the piriformis muscle and the local steroid injection was given in the piriformis muscle, and the patient was absolutely pain-free. So this is the importance of a clinical examination, proper history taking and the examination. With that, we can avoid some unnecessary surgeries, and correct diagnosis is very important. We'll start with one by one. The causes of low back pain can be divided into 6 causes. Mechanical causes, low back pain associated with the radicular pain, inflammatory causes, infectious causes, neoplastic, and visceral. 90% of the cases of low back pain are because of the mechanical causes, which include muscular, degenerative disc disease, or facetal arthropathy. In the mechanical causes, the three main causes include lumbar strain or sprain, which can occur because of the muscle strain. The second is degenerative disc disease, and third is facetal arthropathy. How we are going to differentiate between the two? Whether the back pain is because of the degenerative disc disease or because of the facetal arthropathy. What happens in degenerative disc disease? The patient has severe back pain on bending forward. While in facetal arthropathy, the patient has pain while back extension positions or while twisting the back. So that is the classical differentiation on history. Again, the pain is more of paracentral in the facetal compared to the central in the disc. Causes of low back pain associated with radicular pain include lumbar disc herniation, spinal stenosis, and nerve root compression because of the tumor or cyst. Third most common cause for the low back pain is inflammatory causes. You should think inflammatory spondyloarthropathy when the clinical pattern doesn't fit the mechanical back pain. The classical teaching mnemonic is that inflammatory back pain improves with exercise than the rest. Ankylosing spondylitis criteria includes age of the patient less than 40, incidence in onset, morning stiffness lasting for more than 30 minutes, improve with activity and rest, and not with the rest, night pain in alternating buttocks. It is associated with uveitis, psoriasis, inflammatory bowel disease, peripheral arthritis, enthesis, that is heel pain or chest wall tenderness. On labs, the patient generally do have raised ESR CRP, HLB27 is positive. X-rays or MRI show sacroiliitis and the bamboo spine in the advanced disease. The other causes include infectious and neoplastic etiologies. Infectious includes discitis, vertebral osteomyelitis, spinal epidural abscess, and tubercular spondylosis. In this, the patient do generally have some back pain associated with the fever. And in advanced stages, patients do have focal neurological deficits as well. In neoplastic patient, the most common causes include breast, lung, prostate, renal cell, or thyroid carcinomas. These patients have unexplained weight loss along with the nocturnal pain in the low back, and they might have some neurological deficits. Always consider non-musculoskeletal cause when the pain pattern doesn't fit into mechanical etiology or when the systemic symptoms are present. It can be because of the renal causes, GI or pancreatic causes, vascular causes, or gynecological causes. Patients with gynecological problems generally have low back pain, which is associated with the periods. Do all patients with low back pain need a MRI scan? The answer is no. MRI scan is indicated if the age of the patient is less than 20 or more than 50, if there is a history of cancer, if there are constitutional symptoms such as unexplained weight loss, fever, night sweats, which suggest infection or malignancy, if there are neurological deficits, if there is cardiac venous syndrome, or if there is trauma or risk factors. So the clinical decision making is very important. Proper history along with the looking for the red flag signs, proper physical examination, initial workup, that is ESR CRP if indicated, and the MRI is gold standard if any red flag signs are present. This is the dermatomal distribution for the cervical spine. C5 is basically outer part of the arm. C6 is outer part of forearm plus lateral two fingers. C7 is the middle finger and along with the posterior aspect of the arm. C8 is little finger and ring finger and the middle part of the forearm. And then T1 as shown in the green figure here. This is very important to know because if the patient has disc prolapse at C3, C4 level and the patient is having pain in somewhere C8 or dermatome, then we cannot say it is because of cervical disc. We need to find the other causes as well. This is the dermatomal diagram for the lumbar spine. So this is the L1 which is in the groin, L2 up to mid-thigh region, L2 just below the knee, L4 is the medial aspect of the leg, L5 is the lateral aspect of the leg along with the dorsum of the foot, S1 is the lateral part of the foot and the posterior part, and then S3, S4, S5 is around the perianal region. Simple bedside tests to perform to diagnose whether the radicular pain is because of the lumbar disc or not is SLR test, also called as straight leg raise test, also called as LASIK sign. Here, ask the patient to lie supine and raise the leg of the patient as shown in the figure here. If the patient has pain between 30 to 70 degrees, this test is considered as positive. Sometimes the patient can have hip pain because of the hip pathologies or the low back pain because of the hip pathologies. How to differentiate that? Is by doing two simple tests. One is Faber and second is Fadir. How to do Faber test? It's also called as flexion, abduction, and external rotation test. Also called as Patrick test. And also called as figure of 4 test also, because you see the legs are in the figure of 4. If the patient has pain on the anterior side of the hip joint, then it is because of the hip pathologies. If the patient has pain on the posterior side, then it is because of the sacroiliitis. Again, the Fadir test can be done with the hip flexion at 90 degree. Hip is adducted and internally rotated to look for the hip pathologies. This is the FAIR test. This test is done basically to identify whether the radicular pain is because of the piriformis syndrome or not. As I told you in the story before, we did this test to identify the piriformis syndrome. Patient had lower limb pain because of the piriformis syndrome and not because of the lumbar disc prolapse. Here again the patient lies on the lateral position. There is the flexion of the hip and knee by 90 degree. There is the internal rotation of the knee joint. What is the role of imaging? Should we go for CT scan, X-ray or MRI? The answer is MRI is the gold standard for the lumbar disc prolapse. X-ray can be done for the initial evaluation in case if you are suspecting trauma or tumor. Now the important question is when to refer the patient for the surgical evaluation. Identifying the right time to refer is the key role for the GP. Conservative management should always be the first line of treatment. Referral indications include radicular pain in the arm or leg persisting more than 6 weeks despite conservative management. If the patient has progressive neurological deficit such as worsening muscle weakness or numbness, then the patient should be referred for the surgical evaluation. If the pain is causing severe functional impairment, significantly impacting the quality of life and ability to perform day-to-day activity, then again it becomes surgical indication. In chapter 4, we will understand the endoscopic spine surgery techniques. Basically, there are 3 techniques. One is transforaminal, second is interlaminar, and third is biportal. Transforaminal technique is also called as outside-in technique, where the endoscope is inserted through the neural foramen, which is the natural opening on the side of spine where the nerve roots exist. This avoids cutting through the midline back structures. It is ideal for the farolateral and foraminal disc herniation. What do I mean by farolateral disc prolapse is this. Here the disc prolapse is not in the center. It is in the side, that is called as far lateral disc prolapse. So this kind of technique is very important for far lateral disc prolapse. Second is interlaminar approach. It is ideal for the central and paracentral disc herniation and is most effective at L4-5 and L5-S1 level due to wider interlaminar space. And the most advanced technique of endoscopic spine surgery is biportal endoscopic spine surgery. Here the 2 small incisions are taken on the back, one for the weaving portal, that is for the camera, and the other is for the instruments. Now we'll go through step-by-step process of the endoscopic spine surgery. The patient is typically positioned in the prone position with the padding at the appropriate areas. Choice of anesthesia depends on the patient. If it is transforaminal, it can be done under local. If it is the biportal endoscopy, it can be done under epidural or general anesthesia. 2 5 mm cuts are taken as an incision. Then the dilators are inserted. And then with the help of tubular retractor, finally the picture is like this. There is one incision for the camera and the other incision is for the instruments. The endoscope camera transmits a magnified high-definition image to the monitor, giving a surgeon unparalleled view of the anatomy. Using specialized micro-instrument and radio-frequency lasers, the surgeon carefully removes the herniated disc material or bone spur that are compressing on the nerve root. Since there is very minimal trauma, muscles are spared rather than cut, bleeding is very minimal. The tiny incision is closed typically with a single stitch or a small adhesive bandage. The minimal disruption allows for the swift recovery. Most patients can walk within hours of the procedure and often discharge after an overnight stay. In chapter 6, we will understand the benefit of endoscopic spine surgery. The key benefit of endoscopic spine surgery is infection rate is less than 1%. Since less tissue disruption leads to significant lower risk of surgical site infection. The blood loss is around 10 cc. The more blood is actually drawn for the preoperative investigation than the surgery. Blood loss is negligible compared to hundreds of cc in the open surgery, thus eliminating the need for transfusion. And the incision size is just 2 5 mm cuts. The other advantages of endoscopic spine surgery include quick discharge, quick return to the activity, and the pressure stability. Here the muscles and the ligament structures in the spine are preserved. Hence, spine's biomechanical stability is well maintained. The other advantages include, since we are not cutting muscles here, we are not separating muscles here, there is a reduced risk of long-term muscle atrophy. By avoiding the muscle cutting and stripping, the risk of permanent damage and subsequent chronic back weakness is significantly lower with the endoscopic spine surgery. There is a less post-operative instability. Since we are not cutting big parts of the bone, there is a decreased chances of the spinal instability, and there is less risk of the chronic back pain. Minimizing scar tissue around the nerves reduces the chances of developing fell back syndrome. In chapter 7, we will understand the risk and limitations of the endoscopic spine surgery. While rare, it is important for the patient to be aware of the potential risks, which are common to the most spine surgeries. The risk is very low, less than 1% due to small incision and the minimal tissue exposure, but it remains a possibility. Then the second complication which can develop is nerve injury or dural tear. Accidental contact with the nerve root or tear in the dura can occur. These are typically identified and repaired during the surgery itself. And third complication includes incomplete decompression or recurrence. Symptom may persist if the nerve is not fully decompressed, or a new disc herniation can occur. The recurrence chances is 2 to 3%. Limitations of endoscopic spine surgery includes endoscopic surgery is not suitable for all spinal conditions. It is generally not preferred method for correcting severe spinal deformities like high-grade scoliosis, managing instability requiring extensive fusion, or removing large spinal tumors. The other limitation is the procedure requires a steep learning curve for surgeons and involves specialized, expensive equipment that may not be available in all the hospitals. In chapter 8, we will understand the postoperative care and the rehab part. Postoperative pain is usually very mild and can be managed with the oral analgesics like PCM or NSAIDs. Patients are encouraged to get out of the bed and walk within hours after procedure, and this helps with the early recovery. So this is how follow-up is done after endoscopic spine surgery. On day 1, that is the next day morning of the surgery, patients go home. They can do normal walking, climbing stair, and day-to-day activity. On day 10, we call the patient for the wound check and SOS suture removal if taken any. Then no further frequent visits are required in the OPD. And at 3 months, we start with the physiotherapy for the back strengthening exercises. The role of physiotherapy is core strengthening exercises, flexibility, and body mechanics. In core strengthening, we basically focus on building the strength of abdominal and back muscles, which provide dynamic support for the spine. Gentle stretching, and particularly of the hamstring and hip flexor, improves the mobility and reduces the strain on the lower back. And lastly, education on the proper posture, lifting, and movement pattern is crucial for their daily activities. See, most of the spine patients or spinal stenosis are aged. They are 50 plus. Even we operate at one level, they do have multiple disc prolapse or disc degeneration at other lumbar level and cervical level. So proper body mechanics, that is education on proper posture, is very important for the long-term relief. In chapter 9, we'll see some case studies and the outcome after endoscopic spine surgeries.
This man was presented to a doctor with severe back pain and left lower pain, also called as sciatica. Here you can see he has severe pain and he needed two-hand support to take his leg down. He had tried all he could, including medication and physiotherapy, but without any significant relief. His quality of life was significantly affected, taking him a very long time to get up from the bed. He was walking very slowly, with severe back pain, and the pain in his left lower limb, which is also called sciatica. MRS was very large L4-5 disc prolapse. It was mainly on the left side, correlating with the symptoms. Patient underwent the most advanced version of endoscopic spine surgery, also called as UB, which can be performed by very few surgeons in India. We use 4K camera with an amazing quality here, giving a very good visualization of cord, nerve root, and dura. With this visualization, chances of injury to the dura or nerve is close to zero. Only 5 mm cuts were taken for an entire surgery, and only just two small bandages were applied after the surgery. This is the patient on day one after surgery. Absolutely pain-free and walking without any issues. He was climbing and going down the stairs as well. Hence, it was presented.
This is another patient. This is another 55-year-old patient who had presented to us with back pain, leg pain, and poor quality of life. The patient had significant L4-5 lumbar canal stenosis. He had tried everything he could, including medications and physio, without any significant relief. So the patient was finally planned for the L4-L5 endoscopic discectomy. So the patient underwent unilateral bipolar endoscopic spine surgery, and the lumbar canal decompression was done. This is the patient on next day morning and 1 month post-op. Absolutely pain-free and without any issues. So we have large number of series of the endoscopic spine surgery now. Even if the patient needs fixation surgery, if we want to place screw and rods in the patient along with the endoscopic spine discectomy, we can do that too using a very small cuts, generally 1 centimeter cut per screw. And this is how it is done. So basically, first we place guide wires percutaneously, and then the dilators, you see these dilators here? Then these dilators are placed, and then the screws are placed through these dilators. And then using under CIM guidance, this is the CIM here. Then under CIM guidance, the screws are placed with most accuracy and perfection. This is the continuous CIM monitoring which is done. And the screws are placed percutaneously instead of taking a large incision and opening the spine. So in summary, endoscopic spine surgery provides excellent pain relief. That is more than 80%. A high percentage of the patient report significant or complete relief of their preoperative radicular pain. Complication rate is 3%. And the chances of recurrence is less than 4%. Meta-analysis has consistently showed faster recovery times and shorter hospital stay for the endoscopic procedure compared to the open or microdiscectomies. In chapter 10, we will understand how general practitioners can leverage their understanding of endoscopic spine surgery to enhance the patient care. Number 1 is identify red flags. Correlate clinically the symptoms and imaging. For example, if the patient has L4, L5 disc prolapse, we expect the patient could develop some foot weakness in the foot dorsiflexion or EHL weakness. That is the weakness in external hallucis longus. That is extension of the toe. At L4, L5 level, if the disc is paracentral, that is not in the midline, just adjacent to the midline, the nerve root which is compressed is L5. And with L5 nerve root compression, the first sign of weakness will be at the foot dorsiflexion or EHL weakness, external hallucis longus weakness. We know our hip flexion is controlled by L1 and L2. So if the patient has weakness in the L1, L2 level disc prolapse, then the patient will have hip weakness, hip flexion weakness. If the patient has disc at L3, L4, the patient will have weakness with the knee extension, which is controlled by L3, L4. Then L4 is foot dorsiflexion, and the EHL is L5. Then foot plantar flexion is S1. So we need to know clinically which level disc is involved, and treatment of the correct level is very important. And we should know when to refer the patient. Referring a patient to specialist at a reasonable time can make the significant changes in the patient outcome. Counseling the patient on the treatment options. We all know conservative line of management is the first line of management and can be tried up to 6 weeks if there is no focal neurological deficits. And if patient has persistent pain or progressive focal neurological deficit or bladder bowel involvement, then the patient can be referred for the endoscopic surgery. But what if the patient is quite aged? Patient age is more than 80 years. If the patient had 2 CABGs, bypass surgeries in the past, or for some reason patient doesn't want to undergo surgery, then we can always give an option of selective nerve root blocks. What do I mean by that? This is selective nerve root block. Basically, this is done in operation theatre. Patient is fully awake. It is done under local anesthesia. We place a 22 gauge spinal needle to the transforaminal root in the epidural space. First, we inject a dye, and through the dye, we confirm that the spread is good along the L5 nerve root here. You see the L5 nerve root which is existing at L5S1, and the spread of the dye is confirmatory for that. After that, a cocktail of local anesthetic and the steroid is injected in the epidural space for the pain relief. Patient do have instant pain relief and can go home after 1 hour after the procedure. In short, we'll discuss about the further trend and innovation. The field of endoscopic spine surgery is continuously evolving, pushing the boundaries. The other advances which is happening is robotic assisted endoscopy. It's the integration of robotics promises to enhance the surgical procedure, reduce tremors, and potentially shortening the learning curve for the complex procedures. The other advancement which is going to happen recently is augmented reality and advanced navigation system, which is going to provide real-time 3D guidance, improving the accuracy and the safety. The endoscopic spine surgery is expanding. It's expanding its indications and the technique. We are anyway doing this endoscopic fusion as well, where we are putting the screws also after endoscopic discectomies. And the second is awake spine surgery, which is transforaminal endoscopic spine surgery, which can be done under the local anesthesia. So in summary, endoscopic spine surgery has established itself as a premier treatment for spinal conditions, particularly those causing radicular pain like disc herniation and foraminal stenosis. It offers excellent clinical outcomes combined with the benefits of minimally invasive approach, that is faster recovery, less pain, and preserves spinal stability. General practitioners are pivotal in the patient's journey. Your ability to identify appropriate candidate, make timely referrals, direct impact their success stories. A foundational understanding of this procedure, its benefits, and its risk empowers you to provide effective patient education, counseling, building trust, and managing the expectations. Collaboration is again important. An integrated multidisciplinary approach involving a GP, a spine surgeon, physical therapist, optimizes every phase of the care from initial diagnosis to long-term rehabilitation. If you want to read further, then there are multiple sources available online, which include ECC e-learning lectures, Cleveland Clinic Neuropathways, and Seattle Science Foundation, which provides a vast library of the high-quality surgical videos and educational content from the world-renowned experts in the field. we'll discuss about frequently asked questions. How long does it take? Patients do generally ask how long I'm going to take for the recovery. I have Diwali or I have Ganpati or whatever the festival is. So this kind of recovery we expect in this patient. On day 1, walking is encouraged along with the light day-to-day activities. In 1 to 2 weeks, most patients return to their desk job. And in 4 to 6 weeks, with physical therapy, patient can typically resume the most normal activities, including more strenuous work and exercise. Please remember, individual recovery varies based on the specific procedure, patient age, and the overall health. Now the other question which general people ask is endoscopic surgery covered by the insurance? It is covered by the all corporate insurance along with the CGHS, ECHS, MJPJY, Ayushman Bharat, PMPL, Railway and Police, everything. Thank you. If you have any questions, we'll take it from here.